Hello and good day. So today it's going to be the second part of our critical care nursing, and we'll just be continuing with our discussion. So last time we already have a preview of the anatomy and physiology of the heart, and also an introduction of critical care nursing. So let's now move on here to the next part, which is your diagnostic evaluation. It's all about the blood chemistry, and you've learned this one already in your medical and surgical nursing as well as in your early years in your journey to become a nurse. So it is actually mandatory for us nurses to know the normal values of different and various, blood chemistry. Okay. Now, as you can see in our illustration, there are myriads of diagnostic studies that must be done to patients in order to rule out or to confirm any cardiovascular diseases. Now, you as a student nurses, your main function is to become a nurse educator during this time. You need to discuss the purpose, the expectations, and or any side effects of this diagnostic test that about to perform to our patients. Okay. Now let's move on here. Let's try and discuss first your BUN. Actually, BUN and CREA, they always go together. Okay, always remember that BUN and CREA, they always go together as they are they used to assess and they are the determinants of renal functions. Okay, so your BUN or your blood urea nitrogen, the normal value is already there. It actually reduced in the renal perfusion from the decreased cardiac output. Okay, so if the patient is undergoing any cardiac output imbalances, the renal perfusion actually decreases, which can actually lead to the renal function depreciation as well. Now, other factors aside from having decreased cardiac output is having a dehydration or fluid volume deficit. Okay, how about your calcium? Your calcium is just a quick um, background of this one. It is needed for the blood coagulation as well as for your neuromuscular activity, and you are very familiar with this already. And in terms of your calcium, we have your calpocalcemia and then your hypercalcemia. Now, if ever the patient is experiencing hypocalcemia, it slows down the nodal functions and can actually impair your myocardial contractility. And if there's an impairment in your myocardial contractility, it can actually lead to your heart failure. Now, on the contrast, your hypercalcemia, it increases your myocardial contractility. And we all know that the increase of myocardial activity is actually not good to our patient. How about your, let's just skip your creatinine. We just had a preview with this one. Your magnesium. Your magnesium, it's very good for the absorption of your calcium. And they are also needed for your muscular contraction. We also have two disorder here. We have your hypomagnesemia and then your hypermagnesemia. So if ever patient again will be undergoing or experiencing hypomagnesemia, this actually predisposes to your atrial or ventricular tachycardia. If the patient is experiencing hypermagnesemia, it actually depresses the contractility as well as the excitability. These terms we've already mentioned from the previous session, the contractility and excitability, which can actually lead to your heart block, and finally it can actually lead to your asystole. Okay, and the next one is your potassium, which is 3.5 to 5 mg per liter. It actually plays a vital role in your electrophysiologic function. And we have your hypokalemia can lead to your arrhythmias, and your hyperkalemia can actually lead to your heart block as well as your asystole. And other vital electrolyte that is needed for your electrophysiologic function is your sodium. And you are all familiar as well with the terms hyponatremia and your hypernatremia. Decrease in sodium level, it is from your fluid exists, while your hypernatremia is increase in sodium level, which can actually lead to your dehydration, which you can actually just get through excessive sweating through your daily activities, exercise, playing your sports, as well as if you are experiencing your diarrhea. Okay, so this is all about your diagnostic evaluation. Now let's move on here. How about your coagulation studies and your hematologic studies? So if ever people will encounter injury to vessel walls, will actually initiate formation of your thrombus, and this will actually activate your coagulation. So as we can see here, the coagulation studies are your activated partial thromboplastin time, as well as your prothrombin time, and then your INR. Normal values are already here. Your APTT, or your activated partial protothromblastin time, it measures the activity of your intrinsic pathway. Okay, this is the intrinsic pathway and assess the effects of your heparin. So that we will know when are we going to adjust the heparin therapy. While your PT, your prothrombin time, it actually measures your extrinsic. So a while ago, your APPT is for intrinsic, your PT is for your extrinsic activity, and to monitor the level of your anticoagulant with warfarin. Okay, the former is for heparin, and this one is for warfarin. And your in terms of hematologic studies, you are all familiar with this one, CBC, complete blood count. So you should know the difference between the normal values of male and female in terms of hematocrit and hemoglobin, as well as the normal values for your platelets, which is 140,000 to 400,000, and your WBC. Okay, I hope you are not doing fast, or we are not very fast in terms of discussing this one. But I'm quite sure that you're all familiar with this, as you already took your medical and surgical nursing. Now let's move on here. How about the cholesterol level? And we are all aware about the dangers if we are having a high level of cholesterol in our body, which can actually lead to development of hypertension, and then can lead to blockage in the blood vessels if there are too much deposits of cholesterols or too much deposit of fats. It can actually block the pathways of the blood, when the functions of the heart will be altered, and anything else will follow. So these are the cholesterol levels. We have your heart healthy, at risk, and also dangerous. So most likely the old people are at risk about this one, and also people who are overweight. Okay, now this one, we will just go over with this. It's because this is already discussed in your RLE, or will be discussed in your RLE for further learning. Your ECG, the cardiac diagnostic studies. We all know that this is the graphic representation of the electrical currents in our heart, and it is mandatory for you student nurses to know where to place these things. Okay, so you're going to place accordingly and properly. So you'll learn a lot of this one on your laboratory, as well as during your exposure to the hospitals. Okay, now let's go here further. So this is the proper placement of your ECG nodes, or your ECG. Now here, it's where you're going to put your V1, V2, 3, 4, 5. This one is in the mid-clavicular. Then this one is in your fourth intercostal space, and other things. Now, as you can see here as well, this is an example of grid of ECG. So this is the normal illustration of your PQRST. So this one. Okay, now how about the description of your PQRST? Let's move on here. So if we say P wave, it is your depolarization of the atria in response to your SI node triggering. So this one is, as you can see, there is an elevation on this part of your ECG. Now in between your P and the Q, and then this one, the Q, that is your PR interval. It actually delay of the AV node to allow filling of ventricles. We've learned that one from the previous session. And then this part here, the middle part, that is your QRS complex, which is the depolarization of ventricles, which triggers the main pumping and the contractions. And your ST segment, beginning of the ventricular repolarization, it should be flat. While your T wave here, the last part, this is for your ventricular repolarization. Okay? And how about this one? I think Mom Arsenia will be teaching you more of this one in your ECG. And I've seen some of your activities already and you've done with this one. Section B, you will be learning more of this one with Circa Alim. This is the basic ECG rhythms in which you really need to be familiarized with, especially if you will be having your deployment in the critical care ward or your ICU, intensive care unit. Okay, let's discuss this one. So this is the normal sinus. As you can see, nothing is deteriorated, or in terms of the reading, everything is normal. That is why it is termed as your normal sinus rhythm. Okay, so we are all aware that the heart rate is from 60 to 100 beats per minute for an adult, and other things are here. How about sinus bradycardia? I know you're familiar with the term bradycardia already. Okay, however, if the patient is experiencing this one, it's having less than 60 beats per minute, it means that there's a slow heart rate. The patient is actually considered experiencing dizziness, fatigue, or syncope. We've learned syncope last time as well. Now, your sinus bradycardia may be asymptomatic. Maybe some of the people doesn't know that they're experiencing this one. However, when they will undergo diagnostic procedure like your ECG, it will rule out that they can, they will be diagnosed of having your sinus bradycardia. Now, let's go to the opposite, your sinus tachycardia. And as you can see here in the illustration, the heart rate is more than 100 beats per minute. Okay, here this is usually associated if we are feeling nervous or too much caffeine in our body. It's also a factor if we are we just done with our exercise, we have fever, we have hyperthyroidism, and if we are undergoing some medical regimen. Okay, and of course, if we are situations with places where our body is actually experiencing stress. Okay, so that is your sinus tachycardia. How about your arrhythmia? Okay, usually it's 60 to 100 beats per minute. And this is common among children and frequent among adults. It is not pathognomonic, and this one, it doesn't actually require treatment. Okay? Now, just be familiarized with the proper ECG reading. How about your sinus arrest? Sinus arrest or sinus pause is an indication of your dysfunction in the SA node. And this arrest or pause leads to the dropping or pausing of electrical conduction in the normal sense. This one, you should be familiarized with this. This is your atrial fibrillation. Okay, in your atrial fibrillation, as you can see here, the QRS, there you go, the QRS rate of your atrial fibrillation will be all over the scale. It means it can go fast, then it will go slow, and then it will go back to being fast again. So it seems like very chaotic. That's the proper term for your atrial fibrillation. The ECG reading is actually chaotic. Okay, and with that, we have the three terms here that we also need to know. We have your paroxysmal atrial fibrillation. This is the rhythm that switches back and forth between your AFib and your NSR. While your permanent atrial fibrillation, the atrial fibrillation which is present all the time and the de facto baseline rhythm. While your persistent atrial fibrillation, it runs of fibrillation when they occur that tend to last longer than 1 week or until delivery of small electric cardioversion shock or medication. This will reset the heart back to the normal sinus rhythm. Okay, so let's have a quick review. In your atrial fibrillation, the ECG reading is chaotic, and you need to learn your paroxysmal atrial fibrillation, permanent atrial fibrillation, and then your persistent atrial fibrillation. Now, how about this one? This is your atrial flutter. Now, in terms of atrial flutter, it results from an abnormal circuit inside the right of the atrium or the upper chamber of your heart. Now, if it beats extra fast, about 250 to 400 beats per minute, and we all know that is too much. It's because the normal heartbeat is 60 to 100 per minute only. So you can see this is your illustration. It's like overlapping on this part. How about this one? Your PVC or your premature ventricular complexes. This may be due to stress, activity, valvular disease, CAD, myocardial infarction, coffee, caffeine, antihistamines, decongestants, and the PVC may produce a weak pulse, and it is the client who should be treated and not the monitor. Okay, let's go here. How about your ventricular tachycardia? This one is the heart rate is higher than 120 beats per minute, and it starts in your heart to lower chambers ventricles rather than the normal pathways. Okay. Oh wait, I will just be checking this one. Okay, I think I'm good. Now let's move on here to the next one. I'm actually having a difficulty pronouncing this one, but this one is Torsade de Pons. It's a French term for heart problem. Torsade. If you're American, you can actually pronounce the S. Torsade de Pons. It's a type or polymorphic ventricular tachycardia, which signifies a prolonged QT interval. So you can see here that the QT interval is quite prolonged, and the characteristics that makes the TDP distinct is how your QRS complex twists around your isoelectric baseline during the self-limiting burst. Okay. Now, ventricular fibrillation. This one is where the lower heart chamber quiver rather than it will constrict. And as you can see here, the heart rate is 300 to 600 beats per minute. Okay, so these are just the examples of normal and abnormal ECG reading. I hope you will learn more during your exposure to the hospital and also to your related learning experiences. Now we can now move on to your heart failure. Okay, so heart failure is actually signifies shortness of breath, dyspnea on exertion, or DOE, as well as your paroxysmal nocturnal dyspnea, your orthopnea, and peripheral or pulmonary edema. Most likely it's associated of, having difficulty of breathing if you have your heart failure. So in terms of acute symptoms, the onset, of course, is acute, and immediate or emergency intervention is needed to save the patient's life or the life of people that are experiencing this one. While in terms of your chronic symptoms, it represents the baseline condition and the limitations the patient lives with on a daily basis. Okay, most likely if you're already in the chronic state, it is already irreversible. Okay, and it characterized by relatively stable periods interrupted by episodes of your acute decompensation. Okay, now I also wanted you to determine the difference between your left-sided failure and then your right-sided failure. Okay, and it will boil down to actually knowing where is the oxygen-rich blood and the oxygen-poor blood, or your oxygenated and unoxygenated blood. And as we all know that this is the blood circulation system. So what is happening here is that in the left side a left-sided failure, there's the poor oxygen blood will actually enter our body. And with that, the poor oxygenation, our body will feel tired and fatigued. Okay, aside from that, there's going to be also problem in the brain and also in the kidney, which will be affected. And as a compensation to this feeling, our body will actually increase the blood pressure, in which the fluid in our body will be retained or it will be hold, which actually result to decrease in your urine output. And if the water is being retained in the body, there's gonna be weight gain, in which it is also being experienced in your left-sided heart failure. Now, the next possible that will happen to the person is your pulmonary edema, because there's already fluid in the body. And there's going to be a buildup of fluid specifically in your lungs that will make a person tired and fatigued, as well as experiencing other some sort of your difficulty of breathing. Now let's go to your right-sided failure. It is usually in the right side will have a problem same as the left, experiencing tiredness and being fatigued. Patient will experience weight gain, as well as because the fluid is already leaking and pressure is increasing. Now, when the pressure is increasing, you will be having your distended jugular vein, which is um, very palpable, or you can actually assess this one to the patients who are having right-sided failure. Okay, as well as you know because of the gravity, the patient will actually experience edema in your lower extremities. The fluid buildup will go down. Okay, so that is your left-sided and your right-sided heart failure. Now, how about this one? The causes of your heart failure. So we have your cardiomyopathies, myocarditis, coronary insufficiency, and myocardial infarctions. As you can see here, this one is an illustration of your cardiomyopathy. What is happening here? The myopathies actually are neuromuscular disorders in which the primary symptom is muscular weakness due to the dysfunction of your muscle fiber. Okay, and we all know the meaning of the word itis is inflammation. So your myocarditis is an inflammation of your heart tissue, specifically your myocardium, the middle part or the middle layer of your heart wall. And it actually affects the heart's electrical system and muscle cells, leading to your irregular heart rhythms and problems with your heart pumping functions. How about your CAD or your coronary insufficiency? This actually happens when coronary arteries struggle to supply the heart with enough blood, oxygen, as well as nutrients. And this is actually quite evident if there are a lot of cholesterol deposits, which we already discussed a while ago. There are also plaques, as you can see here. So we have blood clots, plaques, cholesterol deposits. They are almost always to blame with your coronary insufficiency or your CAD. Okay, these buildups actually narrows your arteries, decreasing the blood flow to your heart, and this can actually cause the chest pain, shortness of breath, or even your heart attack. Okay, and your MI, your myocardial infarction, this is commonly known as your heart attack. This is deadly medical emergency where your heart muscle begins to die. As you can see here, the illustration, there's already a muscle damage, and the heart muscles here is beginning to die. Ooh. Now, this is usually caused by the blockage of the arteries that supplies the blood to your heart. Okay, how about this one? We also have your impaired cardiac function in terms of your valvular heart disease. This is your stenotic valvular disease, regurgitant valvular disease. You also have your congenital heart defects, and your constrictive pericarditis. As you can see here, regurgitation means regurgitation, backflow. Okay. Your aortic, your stenotic valvular stenosis or aortic stenosis. It's a type of a heart valve disease. The valve between the lower heart left chamber and the body's main artery is narrowed and doesn't open fully. Okay. Now, if this will not open fully, what will happen? It reduces or it blocks the blood flow from the heart to your aorta and to the rest of the body. It means there's an alteration of the proper flow of the blood in our body. Okay. Now, how about this one? The causes of the heart failure. Excess work demands. Here, we also have your increased pressure work, your increased volume work, and increased perfusion work. What is happening in your systemic hypertension is that the high blood pressure in the arteries that carry the blood from your heart to your body tissues. Now, let's go to your pulmonary hypertension. The main difference between this one is in your pulmonary hypertension, the high blood pressure in the blood vessels actually supply to the lungs, and it's a serious condition that can damage the right side of the heart. And the walls of the pulmonary arteries here actually becomes thick and stiff and cannot expand as well as allow to the blood to go through. It's because there's too much thickening and stiffening of the heart walls. Okay. Now, how about your coarctation of aorta? I know you are already familiar with this one. This is a birth defect. You already learned this one in your maternal and child care. So this is a birth defect in which a part of your aorta is narrower than usual. And if the narrowing is severe enough, and if it's not diagnosed, the baby may have a serious problem and may need surgery or other procedure soon after the birth. It's because, the baby will not be able to survive, or it may survive, but, will face a lot of problems afterwards. It's because the blood flow from the heart is not sufficient. Okay. How about your arteriovenous shunt? This is an operation. You already know this one. Excessive administration of intravenous fluid. And this is also, very critical for us nurses to properly regulate the IV fluids of our clients by properly, following the prescription of our attending physicians. Okay, how about the increased perfusion work? It is actually caused by your thyrotoxicosis and your anemia. Your thyrotoxicosis is the condition in which you have too much thyroid hormone in your body. As you can see here in our illustration. Okay. So, how are we going to assess our client? Of course, by looking for pulmonary edema history. So we're going to ask this one, when did the symptoms start? Is it already acute or it's already chronic? If it's acute, we can actually just, send the patient to the doctor or to check for any specialist. It's because we can just, properly treat this one. But if it's chronic already, it's already irreversible. Okay, how about the duration? Symptoms is persistent, independent of activity, change of position, food ingestion, or other events. Symptoms typically worsen with activity and improve with rest. The cough and shortness of breath may increase when lying down and improve with sitting up. Okay. Now, let's go back first with your pulmonary edema. I think we've discussed this one a while ago. So this is a condition caused by too much fluid into your lungs. And this fluid collects in many air sacs in the lungs, making it difficult to breathe. That is why the manifestation of shortness of breath is very evident to the patients or experiencing this one. Okay? And in most cases, heart problems cause your pulmonary edema. Okay, how about in terms of severity of the symptoms? So the goal is the symptomatic improvement or, if possible, elimination of the symptoms. That is why, as early as possible, we really need to assess our clients. Okay. How about your comorbid diseases? Other kind of diseases being experienced by the client, like CAD, hypertension, diabetes mellitus, your COPD, and your chronic renal insufficiency. In terms of medication, we have your calcium channel blocker, and we also have your um, on the counter, over the counter meds like your non-steroidal anti-inflammatory drugs or your NSAID. This can actually worsen the heart failure and renal function. That is why every time that you're going to give medication to your client and you know that it is, there's an contraindication or it will worsen the situation of the client, you need to go with your attending physicians first. Okay. Cold medicines with systematic decontinence increase the blood pressure. Of course, cold, these cold things, they can actually increase blood pressure compared to those who are in warmer medicines. Okay. Psychological factors, we also have this one. Your non-cardiac factors like remembering to feel or to take the prescription is actually evident, maybe having some sort of forgetfulness. Financial hardships, transportations, housekeeping, it's because you cannot keep up with this one. It's because you're experiencing fatigue already and you're always experiencing shortness of breath. Now, patients living on second or third floor or buildings without elevators may become isolated and lonely, depressed, and will have family dysfunction. It's because they always feel that they are imbecile, or not. It's not imbecile. They feel useless. It's because they cannot work. They cannot do ADL. It's because um, they will be experiencing shortness of breath as soon as possible, as soon as they will start to work. Substance abuse, just like your alcohol and some sort of drugs. Now let's go here. Some laboratory studies. We've learned some of this one a while ago. We have your CBC to determine if the patient has anemia or has infection in terms of the WBC count. Your iron studies here. This is anemia workup, and also to check your hemochromatosis. Thyroid function test as well. We've learned a while ago about your your what is that term again? Your thyrotoxicosis. That is why we need to know as well the thyroid function test. Electrolytes, the effects of the diuresis, the one that the patient is taking, particularly your potassium level. Okay, and with this one, hyponatremia is very common. A while ago, I also mentioned to you your BUN and creatinine level, which is a great indicator of your renal function. Your BUN creatinine ratio, they actually distinguishes between your pre-renal azotemia and as well as your kidney diseases. Liver function tests, especially your albumin, bilirubin, and alkaline phosphate. Oh, this one is repetitive. Other thing here is bilirubin here actually, and your AP, your alkaline phosphate, are often elevated in patients who have liver congestion, which is caused by your heart failure. While your HIV is being used to rule out your, HIV test or HIV/AIDS etiologic factors, while your lipid panel, they use to assess risk for your coronary artery disease and nutritional status. Remember that cholesterol level is one of the most common or one of the most pathognomonic reasons while patients are experiencing heart failures. Okay, aside from that one, diagnostic studies, ECG, of course. They need to check the electrical conductions of the heart. This is actually very useful in identifying atrial fibrillation and ventricular dysrhythmias, which is very common in heart failure. Uh, Echocardiography. This is the reflection of the sound waves of the cardiac structures to recreate two-dimensional representation of the heart chambers, as well as the walls, the valves, and the large vessels. It's like echocardiogram, but this is very specific to the heart. Okay, we also have your ranioculide ventriculography. Okay, um, and also we have your chest X-ray and your exercise testing. Exercise testing is through your treadmill or your exercise bicycle. Management for this one, airway and breathing, intubation. You will be learning in your RLE the proper way to perform as well as to assist in intubation. Your instructor will be teaching you how to do this one. Okay, this one is for the pulmonary edema, persistent oxygen saturation or less than 90, and oxygen level. Of course, the patient will need oxygen to, or to suffice, and for our heart and brain to function properly. It's because our breathing mechanism is already malfunctioning. Maybe there's a need for intubation for these clients. Okay, diuresis, of course, it will reduce pulmonary edema. It's because it will allow the patient to excrete some excess water that is actually being retained in our body, with the likes of your furosemide or your thiazide. And of course, there should be a careful monitoring of your potassium and your magnesium. Okay, moving on here. How about your medication use in treatment of your heart failure? Action indication, starting target, dose, contraindication, and adverse effects. Please read these medicines properly. And you already know this one as you learn this in your pharmacology class. How about your acute decompensation of the heart, the circulation, the function of the organ, the brain, and the kidney? The function of the organs, the indicators of this one in terms of brain is there's going to be confusion. It's because we are lacking oxygen and blood coming from the heart going to our brain. With this one, it can lead to confusion and change in your LOC. Okay, how about in terms of kidney? There's gonna be increase in your BUN and CREA. Remember that BUN and CREA, they always go together, and they are indicative for the renal functions. We also have your metabolic acidosis. Okay, how about your circulation? We have the optimized hemodynamics. One way to increase your cardiac output is to optimize the preload. And if a patient is dehydrated or has fluid overload, contractility is actually being compromised. While you increase contractility to increase your cardiac output, it may be necessary to increase the contractility and decrease your overload. And drugs that increase contractility are called as your inotropes, and all inotropes increases your myocardial O2 consumption, and there must be a greater improvement in O2 delivery than your O2 consumption, so that there's going to be a balance or equilibrium in terms of the delivery of oxygen in the entire parts of the body. How about this one? Your circulation in terms of your inotropes. We have your dopamine, and it is actually an excellent at mild level doses, which can actually have your vasoconstrictor at higher doses. Now, for this one, your dopamine is actually for the correction of your hemodynamic imbalance or imbalances that is present in the shock syndrome due to MI, due to trauma, due to endotoxic septicemia, open heart surgery, renal failure, and chronic cardiac decompensation. Okay, as in your heart is being or feeling congested. It's almost in the state of failure. Okay, and dopamine will actually be the medicine of choice for this one. Now, the renal dose dopamine at low doses of 1 to 3 megs per kilogram per minute stimulates your dopaminergic receptors that dilate renal and splenic circulations. Now, your inodilators are used to stimulate your B adrenergic receptors located in the heart and blood vessels to increase contractility and cause vasodilation. They are also chronotropic. They increase heart rate and must be used carefully and titrated slowly in patients with tachycardia or ventricular dysrhythmia. Now, what I want you to remember here in terms of your chronotropic, this may change the heart rate by affecting the nerves controlling the heart or by changing the rhythm that produced by your AV node. I mean your SA node, not the AV node. Okay, so we have what we term as your positive conotropes increases the heart rate, while your negative conotropes actually decreases the heart rate. Dopamine and miltrinone are drug of choice for this one. Vasodilation, this kind of medication is to properly dilate, the walls of our arteries so that there's gonna be blockage. There's no interruption in terms of the blood supply coming in and out of our heart and all over our body. We have your nitroprusside, the most rapid onset with the shortest half-life. I know you already know or learned half-life in your pharmacology. Now, your half-life is the time that takes for the amount of the drug's active substance in your body to reduce by half. Okay. You also have your hydralazine, your nitroglycerin, intra-aortic balloon counter pulsation, and then your LVADS. How about your acute decompensation here? Heart failure, heart rate. You already know bradycardia and tachycardia. Um, Chronic heart failure is controlling the blood pressure, fluid volume, and the heart rate and rhythm. Non-pharmacologic treatment. We have, of course, your sodium restriction in terms of, this one, no salt shaker in the table. We should not be adding salt in the food you are cooking or in your plate. And of course, we should avoid canned goods or what we term as the, you know, what is that brand again? The corned beef. Okay, if we say corn is actually preserved with the use of salts. In terms of the diet, avoid fast food, of course, frozen foods, fresh lean meats and poultry, fish. Avoid sauces as well. Alcohol use, we should be stopping this one. Exercise should be on low level only. We should not be forcing our body to do strenuous activities or exercises and sports. It's because of course it will affect your heart system or circulation system. Walking, it must be 15 to 20 minutes each day, and of course it should be with assistance. Okay. Medication, it's very important. You have to take your medication on time. And weight taking daily, you need to take your weight without clothes so that the proper calibration of the weight um, will be taken. Okay, and the last part here in our slide is the non-pharmacologic treatment, implantation of a cardioverter defibrillator by ventricular pacing, and of course patient education. A while ago I already mentioned to you that the best role for the nurse during this time, especially in doing your diagnostic procedure, is to become a health educator or becoming a nurse educator. Discharge planning begin on the first day of the hospitalization, referral, close follow-up, teaching, and coaching. Okay, and that's it for this session. I will be sending you again another set of discussion in terms of the coverage of our preliminary exam. So thank you very much and have a good day.